Hello and welcome to episode 4 of CCLG's Research Talks for Parents and Public. I'm Ellie Wilkinson and my job is to share research with our supporters. So firstly, I wanted to say thank you for joining us today, which is the International Childhood Cancer Day. It's a global campaign to raise awareness about childhood cancer and to show support for children and young people with cancer and their families. So just to start with some housekeeping, we'll be holding a Q&A session at the end of the talk, so please do submit your questions whenever you think of them using the Q&A button that should just be in the middle of your screen at the bottom. If you'd like to use the chat button, please make sure you've set the to drop down to everyone or people may not see your message. Also, the chat function has just been turned on, so you might be able to introduce yourselves now. This webinar is being recorded and it will be available publicly on our YouTube channel. We will send you all out the link when it is ready to watch. So this month's talk, called Why Do We Research Childhood Cancer, is being led by Dr Bob Phillips. So Bob is a researcher and consultant from Yorkshire, specialising in evidence synthesis and supportive care for children with cancer. As a consultant, he is also responsible for helping to educate the next generation of children's cancers doctors. And as a researcher, he advocates for patients and parents within research. So without further ado, I'm going to hand over to Bob.
Thank you. It's wonderful to be here. Being obviously in the back bedroom, because that's where everybody lives all the time. Now I'm going to share some slides with you, but feel free to interrupt at any point. Clearly some questions are more urgent than others, and so to answer the question, why am I looking so serious? It's because I get really nervous before doing talks. And this is usually the backstage where I'm all serious and feeling shaky and sick, and nobody sees that. So that's hopefully past now. So what are we talking about? We're talking about research in children's cancer in its broadest sense. And like everybody knows, research can only really be done by people who wear spectacles and drink high quality coffee. Well, that's not entirely true, but certainly high quality coffee is very important when it comes to research. Why do we do research in children's cancer? Because we have patients that we want to get better. Because we want to maximize the length and quality of life to every patient that we have, be they small people who are undergoing treatment or teenagers. And when you contact a teenage ex-patient to say, can you send us a photo that really captures what it's like to have gone through cancer treatment and come out the far side and be living a full, delightful life that really grabs things and rushes forward so we can see how normal everything is, they send you this. And Nick's hair didn't go back after his cancer treatment, but he said, this will encapsulate everything you need to know. And so it is. What do we know about children's cancer and research? We know that research has made things better over the years. You'll have seen graphs like this over time. This is a survival curve. What you can see on it is that you have a thing along the bottom. This is years since diagnosis, and this is the survival percentage. That is the number of children who are alive, starting off with 100%, because they all started off that way, but then children died over time. This is the curves for acute lymphoblastic leukemia, and they're color-coded across different eras back in the late 60s, early 70s, and then going right the way through to the early 2000s. You will notice that over that time there has been improvement. Those survival curves are getting higher and higher, and the drops off are getting smaller and smaller. So what in the late 60s was an almost universally fatal condition now has overall survival rates up in the 80, 85, maybe even 90% now that we're in the later 2000s. You'll also be noticing, I'm sure, that the gaps between those lines are getting smaller. Whilst we are researching, while we are improving things, we're not making as big jumps because all of the easy wins have been done. Now, acute lymphoblastic leukemia, the commonest single diagnosis perhaps, is also a good poster child when it comes for showing how research has made a difference. Though, to be fair, the research that really made that enormous difference was the use of lots of antibiotics and blood transfusions to safely give the intensity of treatment that we wanted to. It's not the same for every cancer type, and many people on this call and many people around the world know this, and this is a similar sort of graph, but you can't really see the difference between the lines. This is a form of high-grade brain tumor in which there has been very little progress over all that time. That's not to say that we don't need to do research, it's just that research doesn't always give you that graph that you saw to start with. The research that gives us that sort of information, because that's research that tells us what's out there in the world, is epidemiological research. It goes out into the world and it captures what happens when somebody gets cancer, or what groups of people get cancer more often than others, or what are the outcomes, what are the ways that it varies if you are from a higher or lower socioeconomic group, or a different race, ethnicity, a different sex perhaps. That sort of counting and understanding can also be the start of us understanding to some extent, why does childhood cancer happen? Epidemiology is that sort of science that was told about in the cholera epidemics, and John Snow mapping the disease of cholera outbreaks and finally going in a dramatic gesture, breaking the pump off the well that was spreading cholera through the water pumps. Now, cholera and cancer, although they start with C, are nothing like the same diseases, and we don't have a water pump that we can switch off, as sadly everyone's aware. And so we do research, we do epidemiology to understand what's going on. And part of that is sort of thinking, how do we make things better? Now, survival is the key objective when we're treating children, when we're doing research in this field. And so we've asked the question, and many people have, of those children who die who were being treated for cancer, was it because the cancer got them, or was it something else, essentially? Because that then lets us ask the question, was it the anti-cancer drugs that failed, or was it something else that failed and led to their death? As an international body, we put together a way of trying to understand that difference. Because if we understand that difference, we know where in the different disease groups we really should be focusing our efforts. Should we be focusing it on improving the cancer get-readiness, or should we be focusing on improving the other things, the treatment-related mortality, the something else's that lead to the deaths of those children with cancer who die? We did a study where we took over 5 years, 30 deaths. Of those 30 children who had died, 20 of them had a solid tumour or a brain tumour, and 10 of them had a hematological malignancy, a leukemia or a lymphoma. When we looked at those 30, we found that 10 of those 30 children who had died did not die of their cancer being out of control, but they died essentially of side effects or adverse effects of their treatment. If we only concentrate our research on trying to get cancer better got rid of, we're missing a large chunk that could lead to improvement, could lead to greater survival. And so why we look into what's not happening, where it's going right and wrong, is so that we can understand where to put our research efforts. Now, as an evidence synthesis person, that is someone who brings studies together, I'm going to show you a couple of graphs that really pull in what it looks like so I can demonstrate some of our sorts of research that we do. This is called a forest plot. It's not because it was invented by Forrest Gump or anything like that. In fact, I don't know why it's called a forest plot. It just is. Each of these different lines going down is a different study, a different research study. And that sort of blob and wings tells you what the results of that study were, where their best guess was the blob, and where they thought the truth would be, which is within the wings. Sometimes, if you haven't got many people in the study, your certainty about the result is pretty big. If you've got loads and loads of people in the study, then you can be normally pretty precise. It's like a little TIE fighter, pretty precise about your results. And what these show is that a whole load of studies done between 1965 and 1990 all gave slightly different results, but they showed that something was on the side, the right-hand side of that big black line. Now, those numbers at the bottom, that 0 to 12, they're multipliers for a bad thing happening. So if everything landed on 1, then the intervention, the thing that we're talking about, would have 1 times the effect on mortality. That is no effect at all. It would be 1 times 1 is 1. It's the same. So these are all saying something is making it worse. But the individual studies are all a little bit unclear, a little bit uncertain. If instead of doing individual studies, as we've done an extra study, we added it to the one before, so that what you're seeing here isn't each line being an individual study, but each line being the adding up of all of those studies as we've gone forward in time, then it would have been very clear that certainly in the mid-70s, that whatever it was that we were doing was doing something bad. It was roughly tripling the mortality, the death rate. Now these graphs are nothing to do with childhood cancer, but they are to do with children. These are the studies of sudden infant death syndrome, cot death, and putting babies to sleep on their front rather than their back. You should be putting babies to sleep on your back, as I think everybody is aware. But it was the mid-90s when we pulled that research together and started to make a difference. It's no good doing research and not putting it into practice. It's no good doing hundreds of studies and not adding them together when we can get a more powerful answer. And we have really powerful reasons to go and do research. Harry wanted us to keep using this slide to show just what mucositis is like, because sometimes people think, oh, it's a bit of a sore mouth. Sometimes doctors say that wrongly. Sometimes it can be that you have to be on more pain relief than you would do if you'd had a major abdominal operation, to the point where you can't actually wake up because the pain relief needs to be so much. And people have tried to prevent this. And we've got a systematic review with these sort of forest plot. And that blob at the bottom is the adding up that shows an intervention roughly halves the rate of severe mucositis. The intervention is called photobiomodulation. How do we get it from that graph into action? Well, an international group called POGO put together a clinical practice guideline. That is, we put the research into a document that would help guide people how to practice. And within that, there was a recommendation to do this photobiomodulation that was based on really high quality evidence drawn over a number of different trials. But putting it into practice still takes effort, and we need research on how to put things into practice better. This happens to be one of our patients who is demonstrating that it is an extremely simple thing to do, and no, the doctor can't hold on to it, and he's going to hold on to it himself. If you want to learn more about that, we've got loads of webinars on photobiomodulation. So if you're a professional and you're not doing it in your centre, come back to us, we'll tell you why. Now, what's really important, and people have often seen ultrasound used, to diagnose children's cancer or looking at all sorts of problems. What's really, really important is to really understand the research you're working with. This is not an ultrasound. This is a radar picture of a storm, and I've just told you as if it's an ultrasound. So at all times, ask for the research, ask for evidence, because you cannot believe people sometimes, and our brilliant ideas are not always right. And that's why we do research that often involves the tossing of a coin. and randomization between two groups. Because sometimes we have a brilliant idea. Our brilliant idea might be that we can use, in order to prevent mucositis, a supersaturated salt solution that will protect the skin in the inside of the mouth. And all that people would need to do is gargle this stuff on a once daily basis, and it would reduce the amount of pain and distress that was done with mucositis. It's a salty solution. It's incredibly straightforward. Surely we don't need to trial that. Well, we don't need to trial it. But when the Canadians did trial it, these are the pain graphs over time, the amount of pain reported by patients post-transplant who are often in a state where they can get severe mucositis. The intervention is the black line. Some placebo, that is some vaguely salty, but not actually super salty with this magic saltiness in it, are absolutely on top of each other. What this means is there is bugger all use in using this drug. Knowing something doesn't work, not spending the money on it, not trying to make somebody who's already feeling a bit gargle something that's saltier than seawater, a small child post-transplant, is better for everyone. Sometimes we have ideas that are right, like when they looked at taking the doxorubicin, which can lead to later problems, it's a chemotherapy drug, out of some of the Wilms tumor patients. The red and blue lines that you can hardly see there completely overlap in the trial, demonstrating that there was no advantage to having that extra chemotherapy drug on there. And that was what the idea was, and sometimes the idea is right. When we've looked back over the trials that we've done in treatment of anti-cancer treatments in children's cancer, and this was done a few years ago now by a distinguished professor of trialology, except they had a better word than that. He found that half the time our brilliant new idea was right, and half the time it wasn't. So genuinely, each time we are tossing that coin, and half the time we're right and half the time we're not right. But if we just went with a brilliant idea every time, we would be exposing people to more drugs, drugs that didn't work, drugs that interacted with other drugs, and we wouldn't go forwards. One idea that I still haven't got everybody else to believe is that when you look at the evidence for the fancy food diets that are sometimes proposed, they generally lead to people being worse off, not better off. If you boil a strawberry before you allow a child to eat it so that it doesn't have any germs on it, you might marginally reduce the amount of germs, but you massively reduce the amount of nutrition, and you completely destroy the quality of strawberryness. We are on with a guideline to try and make that work. So why do we do trials? Because unlike Nike, that's how it used to be said, or Nike, is that how you meant to say it these days? Don't just do it. Bloody test it first. I'm going to do some maths. And so here's a cat, so that you can all calm down. Because apart from those people who have anaphylaxis to cat and can't breathe around them, most people find cats very relaxing. Lovely Mavis, lovely relaxing. Good. Now we're going into high-powered statistics. Not really. We've got the idea behind febrile neutropenia. Low white count, high temperature, might be a life-threatening infection. Might be a cold, might be a slightly dodgy thermometer reading. How do we separate out the white light of febrile neutropenia into those patients who are really going to be sick and those patients who are at very low risk of complications? How can we do that? Well, we did research to try and separate these things out. The research was largely in children, although we knew there was lots of research in this in adults. And we wondered about teenagers. We wondered, does this tool, this way of doing it, work? But it doesn't work so well. So the thing that we came up with broadly speaking, 20% of kids that come in with febrile neutropenia will have something that really, really needs treating, and the other 80% won't. The tool that we came up with managed to split people into a group that was a really quite low risk, 8%, 5% or so, of having something that really needed treating, and a higher risk group. And that low risk group, you could potentially get out of hospital with regular phone calls and make sure they were okay. Teenagers, though, were they different? I mean, they definitely are different. You can see they're green compared to purple children and bald old people who are a sort of a vaguely odd brown colour. But the studies either had them in with kids or had them in with grown-ups. And so we collected together from our friends all of the studies that we could find that had teenagers in them. And then we took the children away and the adults away. And we ended up with what was essentially a study of exclusively teenagers, and it had never been done in the world before. We then did really hard maths using a really hard mathsometer. And we had a professor of statistics helping, actually. It was proper hard. And we demonstrated that teenagers are indeed weird and different. Because if you use the same rule with teenagers that you use with children, you don't end up with the same result. Now, I might be giving you the impression that all you need to do in research is just go out, get other people's research, bring it together, add it up, mush it through some stats, and then you will have the answer to put things forward. However, not all research is brilliant, and sometimes it's pointless just trying to make it shine with a systematic review. Instead, accept what's out there and move on. And certainly that's been the case when we were looking at whether we could use a blood test to help stop people getting extra antibiotics that they didn't need in febrile neutropenia. There was research out there, but it didn't feel like you could put it together to get anything more than a pile of stuff that might have been useful in some settings, but wasn't useful in others because we weren't really fertilizing fields. So we needed to do some new research. What we showed was this blood test. The red ones are the people who've got severe infections. The blue ones are people without severe infections. But broadly speaking, this blood test was different in the ones with severe infections and low in the ones without severe infections. But that's just the blood test. Now, a blood test can do many things. For example, this here is a pair of ducks. This here is a yak. If you take blood from these ducks and you give it to somebody to do whole genome sequencing, which they can do over the course of 4 or 5 days, and blood from the yak and ask them to do the same thing, then in about a week, they will be able to tell you which is a duck and which is a yak. On the other hand, you could just look at them. Sometimes we need to do more research because we get an idea that it might make a difference, like this. It looks like it might make a difference. But how much of this would we have already seen by looking at the patient going, you look like a duck, you look like a yak? Can it add anything over and above? So sometimes we have these early phases of research, but we need to take them a step further forward. Now, I've been talking an awful lot about research that involves counting things and doing things one way or the other, and in a sort of sciencey sort of that sort of way. But really important research doesn't have to happen that way. For instance, we know that people have scans after treatment, and we can do some county type of research to say, does this scan seem to make a difference if people are caught on scan with a relapse or whether they're not? And we know that from looking that people get worried about these things. But what is that experience of anxiety around scans, anxiety? And how does it affect people? And what could we do to make a difference? And so what you can do is what's called qualitative research rather than quantitative research. There are all sorts of research technologies and techniques that are about inquiring about how and why and what happens in a sense of feelings, beliefs, understandings, and putting things together. And these are the sorts of research that can make a difference in loads of different ways. They can inspire us to go down a research path. They can tell us which bits that we're getting right and wrong. We can use qualitative research, and we will be doing, to work out how do we get people to do photobiomodulation with the fancy lights and make the mucositis better. If it wasn't for qualitative research, then there would be areas of the world that we don't really know anything about. For instance, if we assume that all of our patients come from heterosexual families and that none of our patients are queer, then we end up repeatedly asking somebody who has told us that they're a lesbian and don't fancy boys about pregnancy. We mean that families feel that they have to hide part of themselves when they come and speak to us. And it's really important that we listen to people's voices. We listen and we do the research that tells us where are we failing our whole patients in coming forwards. How do we decide what research to do? We should ask people. We should ask the children, the parents, the clinicians, the researchers, what needs researching next? Because it's only by doing that sort of thing that we will know what are the most important things to do and research. And we have done that with teenagers, we've done that with children, young people and families, and it's been done in Canada as well. And this sort of exercise is a piece of research about research. And actually, one of the ways we can make things better in children's cancer is by making our research techniques better. For example, if we could take the studies that have been done in adults that were all about how to stop people puking, and we could understand how we could take that knowledge and use it in children's medicine, then maybe that research on research will mean that the research in children can start from a different place, one step nearer it being action, one step nearer it going into practice, cutting off 2, 3, 4, 5 years, 2, 3, 4, 5 years of kids not being treated the right way. So the research can be on research to improve research. The core of why we're doing it is very straightforward. There's a couple of photos that are quite distressing, but really powerful. And they were of Jessica Whelan. Her dad was a professional photographer, and he wants and wanted people who aren't usually in this room to see what the reality of childhood cancer was like. It was said that we should be aiming globally for a situation where no child dies of cancer. And indeed, that's absolutely true. But I think we should aim higher. We should be saying no child with cancer dies. Remember, 2/3 of the deaths are in cancer, 1/3 of the deaths aren't. And we can make the journey through and the steps beyond better with research. Now, Twitter may be an appalling place that is full of bin fires and run by a person who may be watching the recording. But Twitter has generated the greatest possible description of what childhood cancer is. Because that's what's happening all around the world in all of our research. Groups of children and their families are joining forces, and that's the way that we will improve things, and that is why we need to do research in children's cancer. Thank you.
So, thank you. That was a really good talk, and I also very much enjoyed the cat. So just quickly first, so Emma would like to know if it's okay to share snapshots of some of your slides on social media, because it's just very powerful, the graph of ALL.
Yes, absolutely. That is taken from a journal article that is open access. So one of the things that's really important is that not only do we do research in universities and have them in academic journals so that we can investigate them in great clarity, but we actually make them accessible to people to read and understand. And open access is one of the ways of doing that. We've been promoting within CCLG and many places actually that we should be getting all of the research we do accessible by everybody in the world, not just by people that are rich or people that are connected to universities. So that graphs from there, and I'm certain that that in itself would be shareable. Yeah.
Okay, so next question's from Scott. So I'd like to know, so evidence-proven improvements like the photobiomodulation, how can they make it so that it's mandatory routine standards of care? Because if it's shown to be as good as it is, why is it not being used, essentially?
Yeah, and that's actually a brilliant question that we do not know the answer to. We know that in children's cancer practice, we are much closer to the edge of research in putting things into practice than nearly every other field of medicine. I've yet to find one that is as close. For instance, the work on Ewing's sarcoma that compared two different types of chemotherapy demonstrated that giving it one way was better than the other way. We had that put into practice about 19 or 20 months before it came out in an academic journal that was the result, because the network fed the result of this back. And where you've been part of the study, then you tend to get those results and you change practice and you put things forward. Where it's less useful, less done, I suppose, less quickly done, I think from what we've seen is the supportive care area. So that's the stuff about the side effects, that's about communication, that's the stuff about infection, that's about everything that isn't just the chemotherapy, basically. All of that stuff tends to be done in different ways, not quite as coordinated around all the centres. And everybody seems to have their own little fiddly way. And that's why we're trying to do these guidelines. And what we don't know is how to make people, how to encourage people, not make, how to encourage people to take the guidelines up and put them into practice better. And we have research applications in to try to understand that and get these interventions, get these things taken up and put in practice faster.
So just a follow-on question. Well, just first, I was just going to say this talk is recorded and be sent out, but the person who's asked that, their sound's not working, so I'm not sure why I'm saying it. But do you think that the supportive care aspects, that they're not as put into practice quite as fast because people don't see it as quite as like life-saving? Or
yeah, I think there's a few different sort of elements that probably go together with this. Thanks, Scott. And I think it's partly the fault of the patriarchy. And I'm sat here as a middle-aged white bloke with a beard who was born male at birth. But I think it's largely been seen because it's not big science. It's not doing things with cells. It's about caring for people, and that in itself gives it a slightly different feel. I think that it's partly because it's like, oh well, it's just sorting out infections, it's just sorting out a sore mouth. Yeah, so there's a little bit of sort of downgrading it compared to chemotherapy, which is really special and important, or radiotherapy with massive machines that you have to dig up half of London to work. So I think there is an element of that in it as well. And I think part of it is this scattered nature, that we don't have a sort of a coordinated approach to the research in that area.
Okay, so I've got a few more questions from Scott, actually. So Scott would like to know, have larger scale studies shown with hundreds of patients rather than around 30 or so, shown that 30% of childhood cancer patients succumb to treatment-related deaths versus cancer-related deaths. I think it's just, what's the evidence base for those?
Yeah,
Good. So, question evidence.
Yeah, absolutely. So it's been done in a few different places. It's been done in the Netherlands Central Centre. It's been done in a slightly different way through the Ontario Group collection of data, and the estimates tend to sit around somewhere around a quarter to a third using that type of technique to look at the deaths. There's our report from looking exclusively in first time treatment cancers rather than looking at all cancers, including relapses and stuff put together. That looks something nearer the 30%, and then it's down in the relapses and the multiple relapses, the smaller proportions in that group.
Okay, so got another question from Emma. So she'd like to know about what research is being done or could be useful to try to understand more about what causes particular cancers. She does know about the work in relation to infant leukemia, but just I think other as well. Yeah.
So I think there's a few different ways that we can go at this or try to understand the causes of children's cancer. Some of it is based around this idea of epidemiological work, so where we collect an understanding of who got cancer and who didn't, and what might the differences be between those groups. Some of it is about understanding the paths that go along to having the genes within the cells broken in such a way that means that is then the cancer is then generated from that broken genetics within the cell that becomes cancerous. And some of that answers the how does it happen rather than the why does it happen question, and why can have lots of different sort of aspects to it in a sense. Some of it will be from collecting the whole genome work that has started off in the last couple of years, where we're looking to see what are the genes within the cancer and what are the genes within the child that's developed cancer. And some work from the States where they've done this sort of thing has shown that around about 1 in 10 children seems to have something. And it's not always an inherited thing, but it's largely not an inherited thing. Something in their genes that means they are slightly more likely to develop cancers because they either they don't have some aspect of the quality control mechanisms that make sure that when you make 2 cells from one, they have been spelled correctly in both cases, or they don't have the oh, we spelled it wrong, let's get rid of it mechanism, which is so that there are these mechanisms that may be failing in some, but these are not particularly well battened down and worked out. These are the things that we think might be going on. Now that means that 90% of the time there isn't really any good explanation, and the British Childhood Cancer Survey from back 20 odd years ago and other surveys like it have looked at all sorts of stuff to say why has it happened, and largely they come back with it's not this thing, and there isn't a why. And when you look across Europe, where you have all the different diets, you have the different genetic influences, the different racial backgrounds, the different sun exposure, the different wine exposure, the different sauerkraut exposure, you know, all of this stuff is massively different. But the sorts of cancers that kids get in childhood are near as damn it the same across the whole sway of that, if you take out the thyroid cancers that were secondary to Chernobyl. It's really annoying. Why isn't there something that we can go, that's the cause of this children's cancer, that's the cause of this children's cancer? but people are still working on it in so many different ways.
Okay, so we've got a couple of questions about how children and their families can get involved with research, or what advice you'd offer about joining clinical trials.
Right, so you can get involved with research in so many different ways. You can be part of what gets called in the sort of research literature as public patient involvement. Essentially, that means volunteering to be part of a group that steers a study forward, that says whether it should happen, how it should happen, that maybe is involved with managing the study as it goes forward, with explaining and talking about the results of the study on the far end. And I know there are people on the call who've done that, and in that way you can be involved in pushing things forward. If you're going through treatment or you get to the end of treatment, you can ask, are there any studies that we could be part of? So you can be involved as a participant, and most centres will have a number of studies open. Not every child there is a study open for of some sort, but there is for lots and lots and lots of children, and those studies can be very varied. They can be studies of how did we make this diagnosis? They can be studies of the genetics. They can be studies of one treatment versus another. They can be studies of experience. So there's all sorts of stuff you can get involved in that way, and you can get involved at the I know I've got to sell the CCLG angle a bit. You can get involved in the charitable angle as well. Other charities are available as well. You can get involved by fundraising for research to take place. You can promote awareness of research, and you can try and demystify research amongst other people who might be like, ooh, it's all about guinea pigs. Well, it's very rarely about guinea pigs, to be honest. You can be involved and be the public voice of that. And then if you really, really want to get involved with research that is beyond children's cancer, then the ethics panels that authorise research to occur within the UK all require a volunteer workforce that has a minimum number of people on it that are not healthcare professionals or retired healthcare professionals and academics. They need lay people. Now, some of those, happen to be professors in molecular engineering in plants, but there's a whole range of people that get involved with those ethics committees, and that's another way you can be involved in making research happen and making research better.
So is your advice for joining clinical trials just go for it?
Yes, in its short version. The long version is actually, can you put yourself into this situation and through this situation? And it varies a little bit in which trial you're asking to take part in. The vast majority of the frontline trials, so a new diagnosis of this, that, or the other, the vast majority of those trials are saying which of these two types of things that we do or are done in the world is the best one of these. Both are definitely the right thing to do. There are other clinical trials, and it might be that those are clinical trials for patients who've had 2-3 relapses, and there is no other therapy that's currently available. And then it's a different conversation and a different way of thinking about what do our family really value at this point? And if we go down the clinical trial line here, what is it that we might gain? What is it we might have to set aside to do that? And where should that balance lie? And for those situations, I absolutely believe there is no single right answer. It is absolutely about that family at that point and the trial itself. And those situations, you need to be speaking with the trialists, or with the doctors that you're working with the people you trust about these things, and considering what's important to us and how does this play into it. Okay,
so very good answer. So you've got a lot of questions. I think you've got the most questions so far of any of our webinar speakers. So
clearly didn't give enough information in the talk.
I know, it just shows everyone's passionate. So as a bit of a fun one, Scott would like to know what your absolute favourite piece of research is, either something you've done yourself or something you wish you'd done.
Loads and loads and loads of really great pieces of research, but probably the best one I really wished I'd done was the survival curve of chocolates post Christmas, where a group put some Quality Street in a couple of different wards, and then looked to see on an hourly basis which ones had gone, how quickly had they gone, and why was it toffee pennies that were left at the end.
People value their teeth. So got a question from the Rural Community Council, and they would like to know why treatment for leukemia takes so long, and how did research lead to this treatment?
I am not a leukemiaologist, so I don't know absolutely, but I can tell you what I understand of the story. It was before I was born. It was that long ago that the idea came that if we could block how these leukemia cells took in some nutrients that they couldn't make themselves, but other cells in the body could, then maybe we could slow the leukemia's growth down, and probably not cure it, but we could certainly give many extra months to children with leukemia. And so this was started by giving some of these anti-metabolites, some of these things that block the cellular food. And whilst it worked to that extent, it gave a few months, there were also some patients that were genuinely cured of leukemia. Not many, 5% or fewer, but it was an enormous difference. And then the thoughts were, well, maybe we could increase and intensify. Maybe we could use some of the drugs that are used in adults that seem to work on the leukemia cells. And they found that you could get rid of the leukemia that you could see down the bone marrow, but then for lots of children, it came back again. So they intensified some more using slightly different drugs that looked like they were working, and sometimes it worked and sometimes it didn't. And they thought, well, what if we give just longer, so that then even if there's stuff that we can't see, because this was the sort of the logical process was, well, if we can't see it, but it comes back, so it must be there, it's just we can't see it. If we give it longer at a lower level, then maybe that'll work. Because the way these work is they work when the cell is awake and trying to grow. It then goes, oh, there's some stuff, and it brings it in. But instead of being like a Lego block with bobbly bits on top so it can grow properly, it's a Lego block that's one of those shiny topped ones, so that it can't grow. But the thing's so stupid, it doesn't know when it grows. So it's that sort of idea. So maybe they were coming back because they were asleep. And when they woke up, if you gave it over a long period of time, they would wake up into the chemotherapy and then go, ooh. And sort of, people just extended it. And then, quite a few years ago now, it was seen that boys, male children, didn't do as well as female children. And same sort of logic. Well, maybe if we, because they've got, maybe they're just lazier. Their leukemia is lazier as well. Boys are generally lazier. Maybe if we get it longer, we can even this out. And that was seen to be the case. And now we actually think we understand it differently than that. And so we probably don't need that sex difference anymore if we've got all of the information we need in order to do that. But it's that sort of evolution of ideas, testing things, bringing it forward. And for a period of time, for a ML, this extended chemotherapy was given in a maintenance phase over many months afterwards, and tested in a trial because it works in ALL. Why wouldn't it work in AML? Well, I still don't understand the why, but it doesn't. And that's why we don't do it with AML, but we do it with ALL.
Okay, so we've got 4 questions left if you're still happy to keep going. Okay, so the next one's from Jess Morgan, who was our webinar speaker for the second webinar. So she's asked whether you could talk a little bit about how you decide what research to do first or next, and how you get a new research project started.
Oh, that is a very good question, and it could be the subject of a whole different webinar, possibly by Faith Gibson, about the James Lind Alliance. So how do we decide what to do next? What Jess does, and what I try to do, and what quite a few researchers do, is we look to the patients and families and say, what are the most important things that we can look at? So then you get an idea of what's important to people to try to improve. You then have to compare against that. What do we have that looks like it might be at the point where we can do a trial and push things further forward one step on, where there's stuff that's sort of much lower down the pathway, and maybe it's better to leave the people working in that sphere to do that before it's at the point where the sorts of work that we do can be about taking it into clinical practice. So it's a combination of what's important, what's sort of ripe for the taking in that sense, but also who out there is funding these things at the moment, because funders sometimes do this thing called calls, where they basically say, in the next year we would like to fund something on spiritual care in children, and when you have that, you go, actually that is important. We've got the people that can do that. That's something we should do, because that would be a useful use of our time and the money to do it, rather than investing all the time and energy in trying to make this study happen and then nobody funding it to actually occur. Because there is this sort of it's not begging, but this way of you've got to go out there to get the money to do it. And so some of it's the practicalities that are putting it against that as well, that puts them all together. I think that's the way we should be choosing and driving forward, rather than just, I really like this, we should do more of the thing I really like.
Fair enough. So we've got another question. This is from Sarah, who's actually my boss at CCLG. So she says she's heard that it's harder to publish findings that don't show an effect. Have you found it harder to that it's harder to find about research that showed an idea that didn't work, and is that a problem when we're collecting evidence and learning about best practice?
What an absolutely superb question, playing into the idea of publication bias and selective outcome reporting. And Jess and Scott will probably, who are on this call from the other side, probably be on a major campaign to whinge at people in future about this. If you look to see what has been reported by tracking when somebody said they were going to do a trial and then try and follow through to the end of it, you end up with some trials that said they were going to happen who never ever report their results. If you look into the adult practice of medicine broadly, not cancer medicine in particular, then we find that if you can get hold of those answers, they tend to be studies that didn't show a massive difference. And so you end up with, if you only look for the stuff you can see, you end up with a biased result that says things are better than they really are. Now, there has been a campaign for the last 10 years called All Trials. The idea that every trial that starts should be published in some way. But sometimes it's really hard to get a study published. Quite a few years ago now, me and Professor Gibson did a piece of systematic review looking to see how could you treat constipation in children who were undergoing cancer treatment? Because we knew it would have to be probably a bit different than children who had constipation for other reasons, many different causes. And it happens, well, I mean, if you wander around the ward or run around clinic, you probably got at least a third of the patients have got constipation of a significantly annoying amount, if not a bit more. And we went out and we did a systematic review, pulled thousands of potential articles, got them all down, looked at a few of them in great detail, and we found that there were 0 non-trials that had looked in this area. It then took us nearly 18 months to get that published, as it was rejected by journal after journal after journal. Part of the reason that we kept going is because we are very persevering, alternatively stubborn gits that wouldn't let this go. But it takes a sort of annoyingly odd sort of researcher almost to keep on going when everybody is saying, nah, don't want to publish that, don't want to publish that. And that might be part of why the negatives don't get published, is just worn outness on the researcher front. And so now the ability to publish open access and the ability to publish in different ways actually improves that. And we think we've seen that over the years. We're getting a lesser part of publication bias, this not showing of the negative and the unexciting results.
Okay, so I've seen a couple of questions in the chat, so we actually have about 4 questions still, if that's okay. Yep, okay, I just want to check. So I've got a question from another Sarah who says, Bob, do you believe that cancer is genetic?
I do, but genetic doesn't mean inherited. So I think that most cancers, if not all cancers, are because of something wrong in the genes of a cell. So to that extent, I think it's a genetic condition. It's not genetic in the same way that male pattern baldness, eye colour is genetic. There are some cancer predisposition syndromes that you can inherit, but having a predisposition syndrome in itself doesn't always give you a cancer, or even though it sort of will in the end, that other stuff has to happen as well. And so to that extent, yeah, I think it is. Well, calling cancer it isn't, is it? Cancers are 200 and more different sorts of conditions that all happen to have a similarity.
Okay, so a question from Faith, who you mentioned earlier. So it says it can often feel like, why can it not be possible and just done? So what steps do we need to take to get closer to this point?
I think we need a combination of things. I think we need a quick acknowledgement when people have a new idea about something, that they should be evaluating it in some way, ideally within the setting of research, rather than just doing stuff and not telling people about it, or telling people they should do it without evaluating it. I think we need a more rapid way of moving our research forwards in the way that it is governed, allowed to happen. So through the pandemic, the ethics process, this sort of authorization that happens at a national level, massively increased its rate, and it massively decreased its CO2 by moving purely virtual and turning things around now in the space of 6 to 8 weeks, whereas previously it could be 6 months, 9 months before you turn things around. Every single hospital, though, then has to authorize it for themselves. And those processes can be incredibly slow and laborious, sometimes 2.5, 3 years before it being authorized for use in the country and opened in a particular location. And there are quite a few reasons that go into that, but much of it is inefficient. And there is a national sort of body and a lot of not quite whinging, but work to try and improve that and speed things up and streamline it so that not every hospital has to do the same thing over and over and over and over again. And we need the funding to be more accessible, quicker, and more agile. That's a good word to use, isn't it? That's like a business word. It has to move so that when things move, things can move forwards and be put into practice. Sometimes our safeguards are excessive. and the same degree of scrutiny will be given to a study that involves handing out a postcard to people in clinic to say, how sick do you feel before your chemo? And the same degree of scrutiny on compound X43D that has never been used in humans before. It's probably not sane, but those are the sorts of things we need to improve.
Okay, so just 2 questions left, provided no more come in. We may have to cut it at some point. So I've got a question from Scott saying, how do you as a researcher keep abreast of all the latest research, as surely there is more published than it is possible to read?
Yeah, I don't. I'm utterly not abreast of everything. It's true. Yeah. But what I try and do is listen to people saying stuff and go, oh, didn't know that, didn't know that, didn't know that, didn't know that. And then, you know, partly when in professional mode, pretending that I do know some of these things. And also being on things like the CCLG list and the lists that journals that publish children's cancer stuff, so that at least I see them when they get published, and I go, oh, that's interesting. Oh, being involved with guidelines and certainly getting guidelines when they appear is really good, because that's like a compressed version of all of the good evidence that's been out there, that's already sort of been pre-digested in a sense and then laid out in a way that can be more easily actioned. And so sometimes there's that. And then there's a responsive mode, so that if there's a clinical situation in front of me or a problem that people seem to be facing, then we can go and we can look, what is the best research to answer that question at this point in time, and then try and summarize that so that others can use it. So there's different sort of elements to that, but essentially I can't, no human, not even non-human can. Yeah, but we try our best.
Fair enough. So our last question is from Derek Shan, who says, how can I get involved in paediatric oncology research as an ST1? I'm not quite sure what that is, but hopefully you do.
Yeah, so there's lots of words that are used to describe doctors. When you emerge from medical school, you go into what's called a foundation program, which is where you learn about learning how to be a doctor. Then from that, you normally decide what sort of thing would I like to be when I grow up, and all the sensible people choose paediatrics. But I mean, there has to be others to look after grown-ups. But then in paediatrics, you go through these things called ST, which stands for something beginning with S and something beginning with T. I don't know. And there's eight levels of those as you go forward. So it's sort of specialty trainee. Oh, that's a really good use of letters. So ST1 is the start of learning about paediatrics, all the way up to ST8, where you're just about to become a consultant. So that's the ST thingy. How can you get involved with research? Get involved with the CCLG, understand what's going on there. There's the POTG, the Pediatric Oncology Trainees Group, that runs out of the CCLG, that provides education and opportunities. Talk to the paediatric oncologists and hematologists in your centre, and to get a taster of what's going on there. Look out for academic clinical fellow, ACF, posts at ST3 to get more information about maybe trying out what is it like to be an academic and get involved with research.
Okay, so I think we are all done with the questions, so I think we will leave it there. So thank you very much for joining us this evening, to all the attendees, and thank you, Bob, for your amazing talk and many questions answered. So the talk has been recorded, and we will be sending it out in the next few days if you'd like to share it or watch it again. You'll also be receiving an email shortly asking for your feedback on today's talk. This is so that we can make sure our talks are the very best they can be. So do take a couple of minutes to fill that out and let us know what you thought. And have a lovely evening, everyone. Thank you.
Thank you.
Thanks. Bye.